It is my pleasure to begin and moderate our first panel, On the Radar, Immunosuppressant Drug Coverage. Excuse me. This is an extremely important issue for all stakeholders within the kidney community, but most importantly, for patients, especially those have or who aspire to have an organ transplant, which is, of course, the best care for patients suffering from kidney failure as long as that they're medically eligible to do so. We're honored today to have speakers here to provide both historical context and an assessment as how the kidney community is moving forward with this issue. AAKP believes that immunosuppressive medication should be covered by the federal government for the duration of the transplanted organ, in contrast to the current status, which is coverage for the first 36 months after transplant. In my time as a kidney patient, I have personally witnessed too many of my fellow patients who've had to make tough choices, a hard choice between paying for their medicine, paying for food or rent, for gas, or for other necessary needs. For a brief period, I personally experienced this situation without coverage for meds for just a month. My meds cost me over $4,000, which I quite frankly didn't have. This is real-world impact of not having immunosuppressant drug coverage for transplant recipients. And AAK believes it is a policy that is a dishonor to organ donors. It is my sincere pleasure now to introduce our panelists. And what we'd like to do is have our speakers come up, present individually, then come back to the table, and at the end of the last presenter, everyone will come up to the table here for question and answer. Some of our panels are a little bit larger than others, but we want to be consistent in how we do this. So first, I'd like to welcome up, and I'll introduce everybody, then I'll turn it over. I'd like to introduce Rob Blazer, who's the Director of Policy for the Renal Physicians Association. He is also a past recipient of AAKP's President Award. Then we have Ms. Rachel Meyer. She's Director of Policy and Government Affairs for the American Society of Nephrology and a past recipient of the AAKP National Congressional Advocacy Award. And finally, Mr. Dale Rogers, who is an AAKP National Ambassador, kidney transplant recipient, author of a recent article on kidney health apps that appeared in a recent clinical journal in the Clinical Journal of the American Society of Nephrology. Rob, I'd like to turn it over to you.
Thank you, Richard. And before I get started, I just want to say that it didn't escape my notice, Diana, Paul, and Richard, that the old, decrepit, obviously on the back nine of his career guy gets assigned the historical perspective. Thanks, pal. Anyway, on a little more serious note, there are people in the room who know more about this issue than I do, but I have been around for about 25 years, so I lived through all this as well. And just to your point about how poignant this is, Richard, I was on the phone with a nephrologist from Delaware a couple weeks ago. We happen to have a political action committee, and this guy's going to an event for Chris Coons tomorrow night. So he calls me up. He's kind of nervous about going there, and he's like, well, I want the RPA talking points. And I was like, talking points, schmocking points, man. You don't want talking points. Speak from your heart, buddy. And, living organ donation, that's obvious. And I said in immunosuppressive drug coverage, these are the two things we want you to talk about. And he goes, well, you know what? 2 weeks ago, we had a 28-year-old young woman who, 3 years out from her transplant, can't afford the drugs, and she's going back on dialysis. We had to manage her journey back to dialysis. So this is so real, it's not even funny. So anyway, overview. It's always a good idea to do this, talk about the policy and evolution and development of what's going on here, historical barriers, institutional and perception-wise, Hill Angels, and then I'll hand it off to Rachel. In terms of the policy evolution and development, the ESRD program was created in 1972, and PTL stands for Praise the Lord and Pass the Liquor. Of course, that was a great thing. Very happy about that. Although, interestingly, Congress didn't really have an idea what they were getting themselves into at the time. I think I read this recently that they forecast at the time that they expected maybe 20,000 people would take advantage of the benefit. And we all know it's 20, 30, 40 times that right now. So that's kind of funny, I guess, or ironic, whatever, however you want to look at it. OBRA stands for, I always get in trouble for my presentations because I don't spell out the acronyms, but OBRA is the Omnibus Budget Reconciliation Act. There's been several versions of this over the last however many years. And the one, I believe this is from '86, mandated Part B coverage for immunosuppressant drugs for 1 year. Major victory, that's a great thing. And then they moved on a couple years later to mandate it for 3 years, and that's where we are now. Now, the rationale they gave for 3 years is they thought this would give people an opportunity to get back to work. And of course, they probably didn't account for a million reasons of patient complexity that doesn't happen, and 3 years isn't sufficient, and that's why we're talking about this issue now. There was an IOM report in 2000 that was mostly supportive. Everything in there pretty much said, this is crazy, you ought to cover it for lifetime because people go back on dialysis, that's problematic. But they also kind of qualified it a little bit like, we kind of get why this is complicated too type thing. But anyway, so that was kind of a major sort of thing. There have been bills continually introduced on this issue pretty much for the better part of 2 decades, but none of them has passed. And the Affordable Care Act was actually an interesting little milepost in this whole little situation, because at first there was one point where the provision that would have provided lifetime coverage for this was that close and then didn't happen. And this was kind of a dialysis kidney community intramural sort of situation right there, quite the consternation within the community. It was in the package and withdrawn in under the cover of darkness at the 11th hour, so that was problematic. But the other thing that the ACA did is it sort of fed this perception that the problem's been fixed. I had some times going up on the Hill and I'd say, hey, we still care about immunosuppressive drug coverage. For what it's worth, our doctors have always demanded this to be on our legislative agenda, like I say, for probably the last, I would guess, 16 years. Times when I thought, the issue is kind of past and maybe we should focus on other stuff. And they were like, no, absolutely, we have to keep this on there. But when I'd go up there and talk to people on the Hill, they'd say, yeah, but the Affordable Care Act took care of this. It covers everybody now. And it's like, of course, that's not the truth. And there's that slice of folks who still aren't covered for it. So anyway, then, that's been a problem as well. So Rachel's going to have a lot of big news on this in a second. So I don't want to steal her thunder. But for a moment, talk about historical barriers, kind of institutional. The move to budget neutrality kind of changed everything. I've been around long enough that I remember before there was budget neutrality in Medicare. And if they wanted to cover something and it was a good idea and people said, yeah, let's go for it, it wasn't that you had to find a pay for. Maybe I should step back a bit. What budget neutrality means is that if you're going to pay for something, you have to find an equal offset to pay for whatever you're going to pay for. And that's been in place, I want to say maybe OBRA 95, OBRA 97, one of those OBRA bills put budget neutrality into the Medicare program. So, of course, that created this dynamic that we're in right now. Kind of different issue, but just another illustration of this. There was a period of time when RPA, my organization, sat at the table where the services that nephrologists provide were valued, and we came up with a relatively modest proposal, and the other specialties in the room were kind of like, you could ask for a lot more because we have no idea what you guys do. So, but our doctors at the time said, no, we want to have a defensible position. We want to come up with a number that we feel good about. And they did that. And number one, strategically, that ended up being the smartest thing we ever did because now our proposals kind of sail through because they don't think we're milking the system. But number two, that was a different time. And if that same situation occurred today, they'd be fighting us tooth and nail because there's budget neutrality and you got to pay for everything. Anyway, sorry for the tangent. So that changes everything. An era of intense existential partisanship. When I say existential, what I mean is that if something good for you happens, it must be bad for me type thing. That's kind of where we're at with Congress right now. So, not that necessarily impacts an issue like immunosuppressive drug coverage, but it's a complicating factor, something that has to be negotiated. CBO scoring challenges. if there is one thing in Washington that's going to unite Republicans and Democrats, it's that everybody hates the Congressional Budget Office. Everybody does. Because it seems that sometimes there's no sort of rhyme or reason to how they come up with the estimates that they do. So, and things that you think are absolutely going to be a money saver, they find ways to say, no, they're not. And this is particularly counterintuitive in this situation because, whatever the cost of drugs is, I know at one point I think it was like $17,000, but it's gone down a lot over the last decade. Rachel, I don't know, is the number like 10 or even less than 10 these days, or 7 or something?
CRS report from 2013 said $4,008 is the average.
You see, so this is the young, vibrant policy analyst who knows that stuff off the top of their heads, whereas, I gotta, anyway. So the point being, this was always been counterintuitive to us in the kidney community because dialysis is whatever that is, 90 grand or whatever, and the price of the drugs is now, we're finding out, less than $5,000. What do you mean this is a coster? What do you mean this is going to cost the government money to implement? But CBO found a way to make it work that way. So, and then the final thing is the difficulty that Congress has in getting out of its own way on anything. They can't pass a budget to keep the government open, for crying out loud. So, drilling down to an issue like immunosuppressive drug coverage that does have its complexities in terms of the legislative process, the regulatory process, how do you operationalize a policy that'll make this go forward? That's problematic as well. So not only can't they do the simple things, but God help you if you have to ask them to think about something. So other historical barriers are kind of the perceptions that are out there right now. Another thing that happened, particularly in Republican offices over the last few years when we've been there, is there's some thought that this is creating a new category of Medicare beneficiary. So if you have somebody who's under the age of 65, so they wouldn't have Medicare anyway, and like this 28-year-old woman that I just spoke about, she wouldn't have Medicare necessarily anyway. So there's this some thought that you're creating a new category of beneficiary. And Rachel and I and some other folks in the meeting were in a meeting yesterday where that issue came up briefly, and someone said entitlement, and the person who was a Republican staffer said, "Don't say entitlement. We don't like that word." So, but anyway, so that's one of the perceptions that happened. Then there's the fact that this might be perceived as a niche issue that doesn't affect that many people. Do we really need to fix it? And then, as noted before, there's this thought out there that the Affordable Care Act fixed this, when of course it didn't for some people. So. Hill Angels historically, Rachel's going to have a slide about this as well, about current Hill Angels, but the people on this list have really been there for the last 15 years on this. Senator Cassidy back when he was in the House, but Michael Burgess and Ron Kind, Republican Democrat in the House, and Senators Cassidy, Dick Durbin, who's been there forever on this issue, and Chuck Schumer. I'll tell a story about Congressman Burgess, Dr. Burgess. He through the RPA PAC, I've been able to eat cold scrambled eggs or cold club sandwiches with him probably a dozen times over the last 10 years or so. And this is an issue that gets him fired up, which is kind of interesting because he's sort of fiscal hawk Republican, don't spend any money you don't have to spend type thing, although maybe it's not, maybe it's perfectly right up his wheelhouse. But there's been a couple times where I've been at PAC events for like the financial industry or something, but I happened to go because we wanted to give Burgess some money. And I just, when I introduced myself, I said, thank you for your leadership on immunosuppressive drug coverage. And he'll go off on a 15-minute tirade about how stupid this is, which, all the financial services people are like, jerk, you just blew all our time because the guy's getting ready to leave now. But anyway, that's how committed he is to this issue. So it's great to have these angels there. And they're the type of people. Before I leave, actually, okay, so I'm going to give the handoff to Rachel here. Advocacy has been a huge issue for the last decade or so, but making it happen has been a challenge. But there has been some remarkably positive news. Before I do hand it off to Rachel, though, although I guess you're going to give, oh no, you're not going to give her an introduction. We already did that. Paul asked me to make mention of our Capitol Hill Day, which is this Friday, and we're doing it in conjunction with AAKP. So immunosuppressive drug coverage and the content matter for the next panel, living organ donation, are our two highest priorities. The other two issues we're going to be lobbying on are preservation of the vascular access outpatient settings for vascular access care. What CMS has done in the last couple of years is they've really ratcheted down reimbursement in all outpatient settings for vascular access care. And what they did last year was particularly egregious, and I could talk about this for the next 3 hours, but I won't. But for ambulatory surgical centers, the two highest volume codes, they propose cuts of 55 and 54%, which would probably close a lot of ambulatory surgical centers where vascular access services are provided. So that's a big issue for us. We were able to fight this off last year, and they withdrew the proposal that was in there in the ASC rule for last year. But the indications are that they're probably going to try and do that again this year. So that's one of our other lobbying issues. And then there's a community CKD bill that's out there as well that has provisions for kidney disease education and paying loan forgiveness for nephrologists serving in rural areas, that kind of thing. Kind of a catch-all bill. That bill itself will never get introduced, but there's great provisions like the kidney disease education piece that we want to see advanced, so hopefully that will happen. But with that, I'll say here's Rachel. And my contact information is here. Please do not follow me on Twitter because I don't want to bore you all any more than I have already. But if you're a health policy nerd and are interested in that kind of stuff, then you could do that as well. Anyway, thank you.
For those of you who I don't know in the audience, I'm Rachel Meyer. I'm the Director of Policy and Government Affairs for the American Society of Nephrology. And just want to echo my gratitude to Richard and Paul and Diana and Aaron and the team for pulling all of this together and inviting us to speak on this important topic. As Rob alluded to, there are a lot of others in the room who've been working on the issue of immunosuppressive drug coverage for much longer than I've been at ASN. So just a quick shout out to Troy, Peggy, Bill Applegate, who's not in the room, and others. There's a lot of collective wisdom here. And it's exciting to see our community united on this front in getting this bill across the finish line. So the topic of my topic is where are we now? And I think we are at a moment of unprecedented opportunity to finally get this decades-old policy challenge across the finish line, really in the coming months. So I'm going to talk a little bit about the context, where we are in terms of this administration and its unique focus on kidney care issues. Rob alluded to one of the challenges that we've seen in the past is kind of Congress getting out of its own way to get legislation done. So coming in the context of an administration that has a really unique and personal focus on kidney care issues can help to overcome some of that aspect of the barriers. We've recently, and I'm going to talk a little bit more about this, gotten a confirmation from two credible sources in the government that this bill will actually now save money, something I think everyone in this room has known for a long time, but we've never had an official confirmation on that front. There's continued collaboration across, sort of on a bicameral and bipartisan basis. And there's broad agreement in the kidney and transplant community. We're all working on this together. And I think shared sense of urgency up and down Pennsylvania Avenue, sort of across both chambers and throughout everyone in the room here today and the broader community. So, as many of you are aware, the Department of Health and Human Services leadership has a number of very personal connections to kidney disease in general and to kidney transplantation in particular. So Secretary Alex Azar, shown in the center of this slide, his father was actually on dialysis. He did hemodialysis, he did home dialysis through peritoneal, and ultimately received a kidney transplant from a living donor. So this is an issue that's really near and dear to his heart and something that he is personally prioritizing work in the Department of Health and Human Services on. To his left, you see Adam Bowler, who's a senior advisor to the Secretary. And Adam's aunt, and this has all been shared publicly, so there's no HIPAA violations going on here. His aunt was also on dialysis. And then Admiral Giroir is co-leading, together with Mr. Bowler and the Secretary, the development of an HHS-wide kidney strategy. And the Admiral is actually a physician, a critical care pediatric intensivist, so has also seen firsthand both the challenges and difficulty of families considering whether to do donation, as well as the challenges that families and children face when they're in need of an organ. So you've got a lot of critical mass of people who care about this issue and understand it on a personal level within the Department of Health and Human Services. And this is important because, as Rob explained earlier, one of the biggest barriers that we've had historically is getting our arms around what might this bill cost or save. and identifying the patient population that would be affected, what would this ultimately look like when the bill comes over to the federal government. These have been difficult questions to get answers on historically, but now that there's a sense of urgency amongst the top leadership, they can help us as a community procure answers from HHS and from Medicare that then help us drive this policy across the finish line on Capitol Hill. So, the last 6 months has been very busy in the Department of Health and Human Services on this specific front. So in early February, a number of groups in the room, RPA, AAKP, ASN, and others, actually had the opportunity to have a meeting with Secretary Azar and Adam Boehler and Admiral Giroir to talk about what do we see as some of the biggest barriers in kidney care in general and in transplantation in particular. And we actually raised this challenge of the Congressional Budget Office always says this costs a lot of money, but we think it's because they don't have very good data about who the patient population is that would need to take advantage of the lifetime coverage because they don't have insurance through their employer, through an ACA individual marketplace, or otherwise. So I think they took this to heart because in March, just about a month later, when Secretary Azar testified in front of the Labor, Health, and Human Services Subcommittee on Appropriations, he was asked a question by Jamie Herrera Butler, who, as many of you know, is a member of Congress from Washington whose daughter was born essentially without a kidney and who was a beneficiary of a transplant from her husband. She asked the secretary about this issue. I know many folks in the room had been whispering in Congresswoman Herrera Butler's ear about this as an issue. And she took the opportunity of having the secretary at this appropriations hearing to say, what up, basically? Is this a priority for you? And what are you going to do about it? And the secretary was prepared with an answer, and he said, check, this is a priority. It's a personal priority. And the Office of the Actuary within Medicare has done a preliminary analysis that actually shows that this policy change of lifetime immunosuppressive drug coverage would save the government money. And I'd be happy to send it to you, Congresswoman. So that was a huge, huge sea change. Previously, no one in the government had ever been willing to say that this policy change would save money. Probably the biggest obstacle to getting this thing across the finish line. So it was a little bit of time before we actually saw that report, but in the intervening weeks, there was a broad stakeholder meeting at the White House with the Office of Domestic Policy Counsel to talk about the importance of extending lifetime immunosuppressive drug coverage and to answer a set of very difficult questions from people at the Office of Management and Budget. And as you heard Paul say in his opening remarks, you know, it's critical and has always been critical to have the Office of Management and Budget, which provides advice to the White House and looks at cost issues, understand the importance and kind of align with your viewpoint if you want to get anything done. So that was an important and positive conversation in April. More recently, in May, we were, as a community, gifted not one report, but 2 reports coming out of the Department of Health and Human Services that both show cost savings. So in the right-hand side here, the little CMS logo, that's the report from the Office of the Actuary that Secretary Azar talked about when he testified to Congresswoman Herrera Butler. This report shows that over 10 years, expanding lifetime immunosuppressive drug coverage would save $300 million. Yeah. The last time we got an estimate on what this bill would do from a financial perspective, it was going to cost about $400 million. So this is, I think this reflects many different factors, including reduction in the cost of drugs, expansion of insurance options through the Affordable Care Act, and a number of other factors, but that is a big win. There was a second report that also came out from the Department of Health and Human Services Assistant Secretary for Planning and Evaluation, ASPE. We do love a good acronym. So ASPE said, we're going to be super, super, super conservative about this. I actually think they used the word conservative 12 times in a 6-page report to underscore just how conservative it was. And they said, we think that this lifetime immunosuppressive drug coverage would save $73 million over 10 years. Okay, it's less than 300, but we're still in the black. And what's important is that the ASPE report underscored that the more people who took advantage of the benefit of lifetime immunosuppressive drug coverage, the more it would save. So the trend line is positive. So they're conservative, but that's kind of your floor for savings. So I think these reports give us as a community real ammunition to drive rapid change in Congress and get this bill across the finish line, because now we don't have to figure out how to pay for it. In fact, we can give it to committees of jurisdiction and let them use the savings from this bill to pay for other priorities that they have. So this is a real opportunity for our community to sing the praises of the right policy now also coming into the black. And as Rob alluded to, there is strong bipartisan collaboration on Capitol Hill with a group of champions who so deeply understand this issue because they've been working on it for years. Frankly, probably longer than any of them or any of us want to be working on it. It's time to get this across the finish line. So just to give a quick shout out, Dr. Michael Burgess from Texas is the lead Republican on this issue, and Rob could tell the war stories about how he gets fired up about this, but suffice to say, I don't think we could ask for a better leader on this issue. Over in the Senate, Bill Cassidy is going to be the R lead, also a physician who really understands this issue deeply. Ron Kind, back in the House, is the Democratic lead, and Senator Dick Durbin, the whip, so we've got a good leadership angle here in the Senate's going to move forward. Rob had mentioned a meeting that we participated in along with Peggy and Troy and Scott and others in the room yesterday, where representatives from essentially all of these offices all got together in a room to say, what is our strategy moving forward? How are we collaborating with one another? How are we leveraging these reports and other data from CMS to talk with the Congressional Budget Office to make sure they agree that this is going to save money? So really, you've got collaboration at the highest level going on Capitol Hill, as well as engagement with the community. The Senate Finance Committee, the House Ways and Means Committee, and the House Energy and Commerce Committee are the committees of jurisdiction on this. And we know that they're actively looking at this issue and see it as a long-standing priority. I think the most likely scenario for a bill like this immunosuppressive drug coverage bill, which in the grand scheme of things is pretty small, is that rather than being passed as an individual piece of legislation by itself, most commonly it would get wrapped up into a larger package of bills that are all moving together with a sense of urgency. So I think the staff on these committees are already thinking about what are big packages that we could pull in the immunosuppressive drug coverage legislation to make sure it gets across the finish line quickly. I've already alluded to this. There's broad agreement within the community and all of the organizations on this slide, as well as many organizations that are not listed here because I just ran out of time, and that's a lot of logos to put on one slide, are all aligned and speaking with one voice, led on Friday on the Hill by RPA, with this is one of their lead signature issues. So again, shared sense of urgency to get this legislation introduced now that we have these reports, leverage these reports and additional data from CMS to actually get that score from the Congressional Budget Office, who are the ultimate arbiters that the thing saves money. It really does come down to their decision and whether or not they agree with the two reports put out from the administration. But again, we've never had this good of an opportunity going into having the Congressional Budget Office look at this. Our job then as advocates, everyone in this room and everyone who's following along on social media, is to add a bunch of bipartisan, bicameral co-sponsors and elevate the sense of urgency on the Hill. Continue dialogue with the committees of jurisdiction and listen to their ideas about where they want to stick this provision in a larger package. I think there's been some talk that drug pricing legislation might be one home for this. There's been talk that this extenders package that is going to extend some revisions to tax law might be another home because that has to get done. You always want to attach your bill to something that has to get done because there's a good chance that Congress might get in its own way and not get it done unless it has to get it done. And even then they sometimes don't get that done. But so you're probably thinking like, sweet, we got this in the bag. What could possibly go wrong? But I do think there are a couple of missteps that we as a community just need to be aware of so that we avoid them. I think the general theme here is we need to keep up the sense of urgency on this. We've got these reports. These reports are not going to be fresh forever. Data changes. We've got a supportive administration that wants to help drive change on the Hill. And we've got a unity within the community that I don't think is ever in jeopardy, but it's time to capitalize on that. So I think if we fail to swiftly introduce the bill, we might miss the window for the Congressional Budget Office to actually say, oh, we agree, this does save money, And then we miss the window to attach the bill to other provisions that have to move that Congress is going to be passing later in the year. I think we've never had data this good that says that there are savings and that we know what the population of patients who will be covered by this extension of benefits, even though don't tell Republicans I said that, is. If we miss the chance to leverage those reports to influence CBO, we've squandered our best opportunity in like 2 decades. Again, if we delay the introduction to the fall, or if we delay the introduction to 2020, we're then running into presidential election politics. There's possible turnover amongst our champions within the administration who really helped to procure this OACT and ASPE report. And just generally, if we start to think that time is not of the essence, we are going to miss a really unique window, possibly the best window our community has ever had to get this across the finish line. So as a community, I think we all are rallied together, and we can continue to rally you and your friends, neighbors, colleagues. The time is now. We got to get behind these reports, thank the administration for helping to procure them, prepare to thank our congressional champions for their continued leadership on this issue, and just rally everyone you know to get behind this and create that sense of urgency to enact this and enact it quickly. AAKP is a long-standing champion on this issue. RPA is a long-standing champion on this issue. NKF is a long-standing champion on this issue. All of the logos you saw on previous slides are champions, and if you're not already involved with one of these groups, I encourage you to get involved and lend your voice to the broader initiative. So I'm optimistic. I hope you are all optimistic, and look forward to hearing from Dale and to a panel discussion. Thank you.
Thank you.
Good afternoon, everybody. First, I'd just like to thank AAKP in the effort that they put forth for us patients, really, to be able to come to something like this and have a voice in it. And that's important to us. To start out with, Richard alluded to the hardship that it causes on patients, and that's kind of what I'm giving right now is kind of the patient's voice and different things that's going on with patients, talking about the immunosuppressant bill, and it's keeping patients from living. And I'll give you several examples of that. Myself, I just hit my 3-year mark on my last transplant here. And I do have a little bit of a different attitude than some patients. I knew of this coming up in 36 months, but I knew that I couldn't live on dialysis. And so I told my significant other, yes, it's going to be a problem, but I'd rather deal with that problem at the time that it comes than live like I am now. So I chose the transplant route. Okay. There's dialysis centers out there from the area that I come from that are making patients prove before they'll allow them on their list to show that they can pay for the medications before they'll allow them on their list to be transplanted. And so it's stopping patients from living and having the chance to live before they even get a chance because they can't show that amount of money. And the amount of money that has to be put out for these medications, these immunosuppressants, to live is huge. In my case, I was on dialysis 8.5 years. And you're out of the job market for 8.5 years. Try to go get a job that'll give you the money to live and pay for medications. Nobody wants to even look at you. You've got to prove yourself, and you can't prove yourself. And you have medical issues that could come up. And so the immunosuppressants would take that side of it out, because you could say, I could go to work, and I could go to work for a lower amount of money, but I'd still be able to live. 95% of kidney transplants are lost because of medication issues. I was sitting in on a meeting with the transplant organization from the University of Washington, and they were asking some of us patients, how can we get the patients to take their pills? And so we were talking about the things surrounding it, and they were saying, We got patients that can't afford their meds, and so they're splitting them in half so they last 2 months instead of 1 month because they can't afford them. And so if we can push this immunosuppressant bill in and then push it through, we would take that out of it. I mentor in several dialysis units in the area that I work or live in, and one of the patients that I see on a regular basis, her name's Elizabeth. I won't tell you any more than that, but her name's Elizabeth, and she had a transplant about 14 years ago, and she had a disorder that causes her blood to clot, and so her transplant made it 1 day. And so she's automatically in fear of having a transplant. And then when she goes to a transplant center and hears about that her meds are going to stop in 3 years if she can't afford them, she's like, I have too many fears to do this. And she's crying, telling me, Dale, what do I do? I can't get a transplant because I don't want to lose another one. She lost her brother's transplant the first time. And she's like, what do I do? And I says, you have to move forward because look at the life you're going now. And she's like, but I can't do that. And so this immunosuppressant bill would allow that fear to be taken away from her so that she could see her road to get another transplant. And so the patients that are out there are living in fear because they're afraid they can't have their medications. And a simple bill that would save money that we just learned would help these patients live a life again. Because I'm sure you can talk to many people that have been on dialysis. Dialysis isn't a life. And so, where do we go from here? Anything we got to do to get the immunosuppressant bill passed. And so my question is to the two of you, as we come back for a question and answer thing, is what do us patients need to take back to Elizabeth to say to her, this is what we need to do to make sure that this gets passed? And so that's my question. Where do we go and how do we get there to make sure that this happens?
All right. Thank you, Dale, for sharing that with us. The other panelists, please come up, and we're going to open it up for questions and hopefully answers. Yes.
Thank you. That was very helpful.
Please state your name and organization for the
My name
record.
is Holly Wittenberg, and I'm a consultant of one at my company. But curious about the number of lives that 300 million covers. Obviously, when you're talking to representatives, it's always helpful to sort of give them a sense of the number of people impacted. And then the other question I had is I read somewhere that a lot of patients are staying in the individual market with the SRD. Can you talk a little bit about that and if it's related? I don't know if it's related, but
Yeah, sure. Here we go. Hi. Thanks for your question. I'll take a crack at this and then also let Rob add on. So in terms of the individual market, I'll work backwards here. I think probably yes, that there are many more insurance options for people who've gotten a kidney transplant who are currently exiting the Medicare program after 36 months have at their disposal. And importantly, the rules that govern all of those new insurance options also say that they have to cover sort of the baseline of immunosuppressive drugs. So I think that has significantly decreased the need for the number of people who actually take advantage of Medicare lifetime coverage of the drugs. Another important reason is that the proposal on the table is only for coverage of the drugs. It's not for full Medicare coverage. So really this is sort of seen as an option of last resort. That if you have a way to get any other insurance, whether it's an individual market elsewhere, as a patient, you're probably going to want to do that. We also want to make sure there's a safety net so you don't skip your drugs or, to your point, go halving them because you're struggling to pay for them. And I think I want to give a shout out to the National Kidney Foundation, who's actually suggested a revision to the current version of the legislation that would clarify that the individual marketplace is another place where people could go to get this coverage, if not through the Medicare program itself. So all of this is driving towards the number of people who would need to take advantage of this benefit because they can't get coverage elsewhere is significantly smaller. The report from ASPE actually used the number 375 as a snapshot of what they thought in a given year would be the population. There's another estimate from CMS that shows a slightly higher number, maybe like around 1,000 patients, but we're really not talking a significant patient population here in all likelihood. The other important thing to remember, and then I'll hand it over to Rob, we'll take another question, is that because the trend lines are positive according to both OACT and ASPE, the more patients who do take advantage of it, although we do hope it's the last resort, the more money it will save. Because there's finally recognition that, hey, a transplant is cheaper than dialysis, so anyone we can avert from going back onto dialysis is going to save money. So it's a small population, but it's an important population to ensure coverage for, and the more people take advantage, the more we're going to save. I think would kind of be the narrative back to Congress on that one. Rob, anything else to add there?
I really have nothing else to add. I told you guys she's a superstar, so got pretty much every answer there. The one point I'll make about is the fact that the Affordable Care Act, as great as it was a little bit of a confounder for this. As Rachel noted, there are a bunch more options for patients to get insured, and the mandated benefit, that's not the phrase, whatever, essential health benefits, that includes immunosuppressant drug coverage, so that meant they had to do that, which is an interesting thing, and not to be political, but there's some erosion of the essential health benefits that are going on right now, and that's problematic because for this issue in particular. Although if that were to go forward, but we were to get our bill passed, then maybe that increases the number of people who have to use it. So anyway, but nothing else to add. Rachel had the right numbers on the patient census.
Next question. Well, Dale, let's get to your question. Dale asked the question, what is it that the two of you would suggest that he take back to Elizabeth in terms of giving her some hope and some ideas as to where we are so that she can move forward from where she currently is?
Well, I would say the hope on this issue, Rachel drove this home wonderfully, it's never been this good, and it'll probably never be this good again. So now really is the time to do this. So the hope is that it's never been this good, but it would be really bad if it didn't happen soon. So what to take back to Elizabeth and everybody in her category in the world is to say, you really gotta get, advocate as much as you can, reach out to your members of Congress. I'm assuming AAKP has some sort of grassroots type of thing where they can weigh in on this. If not, they're welcome to use RPAs. But anyway, I mean, that would be what to do, I think, is to make sure members of Congress keep pounding them on this. The thing with those grassroots letters is people in the House offices and Senate offices are checking out how many emails they get on this, and that gets reported up. So I would say tireless advocacy, understanding that it's hard for folks who have health challenges. But
The other thing I'd add, and thank you for sharing your story and her story, I think it's what motivates us to do the work we do here in Washington, so thank you. Another thought, and this goes for everyone else in the room as well who's traveled to be here today, August recess is a great time to interact with your member of Congress face-to-face in their home district. So if her health condition is such that she is able to say, go to a barbecue or go to a town hall or something and just ask the member where they are on the immunosuppressive issue and encourage them to support this, there's no better way to capture a member's attention than in that period where they're at home and interacting with the constituents that they serve.
And I want to say one other thing about your sharing your story. We're Washington desk jockeys. Really, when you get down to, I sit and look at my computer terminal all day if I'm not doing something on the Hill. When that doctor told me 3 weeks ago about his 28-year-old patient who was going back on dialysis, and I had to sit the phone down for a second. I was like, oh my God. But, so the real life stories on this are so essential, and to the extent folks feel comfortable sharing them, it's so meaningful.
Let me also add a couple of points here. Is that number one is that the Action Center, AAKP, does have an Action Center that I'd like to refer Dale and anyone else to. And if you go up there, you will see we have some information on living donor. on the Living Donor Protection Act, as well as immunosuppressant medication. Part of what we need to do as a patient community, working along with our colleagues, is that we need to vote. We talked about voter registration this morning. We need to vote. Then we need to, as we visit our legislators, we need to let them know what we want, which is the extension, and also that we do vote. There's one thing that all congressmen and senators have in common: Republican, Democrat, Independent, Russians, it doesn't matter. They can count.
Delegate from Moscow.
They can certainly count. So to the extent that they understand that we do know about this, we are going to be watching them, and we do vote, you will be surprised at the tremendous impact that that will have on a legislator. You can have a significant greater impact if you're small in numbers, but you're significant in terms of the way that you vote. So that's one thing that you can bring back. And people doesn't think that it works, but it really does. And over the period of time, and the time is right now. Let's see if we can get another question in from this intelligent group we have here. Silence. Well, I have a question. We've been doing this for a while, and we finally found out that, or we have the proof and the data, that the numbers seem to suggest that we can actually save if we do this. We're going to go up on the Hill with RPA, and certainly when it's time again for ASN, we'll be joining you, as well as Troy Zimmerman is here with NKF. We'll also be going up on the Hill. Is there anything else that we can do? For example, this is national in scope. Is there anything happening on a local basis? Should we go to hospitals? I just want to make certain that we cover all bases so that our patients are educated, the professionals know that we're there to support their efforts. Certainly the docs obviously are so critical in this. So just to make certain that we cover everything that is out there. Being more aggressive, or is there such a thing as being too aggressive? Rob's an aggressive guy. What do you think?
I'm really not, Richard. I don't think at this moment there is anything as being too aggressive. I mean, you can be assertive but not difficult, and I think that's the thing to do right now. Not antagonistic, but I mean, I don't think you can email your members of Congress too much on this kind of thing. It's particularly right now. If this were 2 years ago, I would say, well, you want to pick your spots, but this isn't a pick your spots time. This is all hands on deck time.
Amen. I told you I learned everything from Rob, and that was the perfect answer. I think from a tactics perspective, the only thing that I would amend my earlier statement about if you have the opportunity to try to meet with or attend an event that your senators or representatives are at when they're home, or the July 4th or the August recess, is if you're a patient, get your nephrologist to go with you. There's no more effective, I think, united front than you can present to lawmakers than a patient and their health professional talking about why together they think this is an important policy. It's why, as Richard explained, you heard that RPA, NKF, ASN, all these patient and health professional organizations work in collaboration, because we've learned that that is the most effective way to bring lawmakers over the finish line to agree with the policy positions that all of our organizations share. So.
And with regard to the district visits, I would say if you were able to set one of those up for August, number one, the chances of you getting time with the legislator are probably a lot better, and getting a lot of time with the legislator. If you did this in DC, and you're, we're having these Hill visits on Friday, there's going to be a few that are going to come over, hey, let's take a picture, and that's it. Whereas they'll totally glad hand you. Whereas if you do it in the district office, you might get a half an hour of FaceTime with that person. And that's a tremendous opportunity to do that. So Rachel's absolutely right. The nephrologist-patient combination is really wonderful. And if people were to do it in their districts, it doesn't have to be during a recess. If you can get them on a weekend too, easier said than done. But maybe that would be really powerful.
Yes, sir.
I have a question. So, emailing your congressperson, right? That's super important. But where's the language? You know, like how do I email? Well, I don't have any congressmen because I live in DC, but but I mean, like, you know, is there in this AKA, you know, KP
Action Center.
Right? Is there like a language and like my senator, or you know, if I had lived in Missouri, if there was like the senator's email, and then can we pass that out to all the dialysis centers and get those social workers and those dietitians involved? And I mean, like, I feel like that's the way that we can get patients easily involved with that if they have wording.
Yeah, I totally agree with the point you're making. We need a groundswell of grassroots advocacy from across the country speaking loudly and urgently on this issue. I'm going to deflect actually this question back to Richard to talk about the AAKP Action Center, but I think AAKP and every other organization that's been mentioned, RPA, NKF, ASN, ASTS, all of these groups have these types of talking points as well as portals where you can go online and they'll like auto email your member for you if you just fill in your zip code. But I'm going to let Richard talk a little bit about AAKP's specific offerings on this front.
Yeah, let me speak to that very briefly, and then we will certainly move forward. First of all, we advocate, we don't lobby. But certainly, as you go to the Action Center, and this is what it's all about, AAKP is established to educate and advocate for patients and really caregivers and anyone else. We have a free membership, and as you peruse the website, if you go specifically to the Action Center, the questions that you asked are answered. And if you just go to the website, aakp.org, you will be able to locate the Action Center there. And as we need to update it based on whatever is going on with the legislation, we will do that. But we provide the tools that you would need to be able to contact your legislators and send correspondence to them. And we have the rest of AAKP staff. Aaron is here, and Deb and Diana, and they can really tell you the details about it. So that's available, and that's part, as an organization, we have our ambassador initiative where we have patients such as Dale who are a little bit more educated than your common patient. And our role is to grow that number. We're on the way to, I think we have maybe 125 or 150 now, but we're looking to grow that number to over 400 2020 because we want these patients to be educated. They can share this information and talk with the other individuals. We have a new ambassador right here. She's here getting a lot of information, and she'll be out there sharing this back down in the Richmond area, the great city of Richmond. And that's really what it's all about, getting this information. When I hear someone say to me that a patient didn't know that they had an option of getting a transplant, that a patient didn't know this, that is simply unacceptable. And we do this by educating them, and the more educated they get, they will understand that it's incumbent upon ourselves. We are not victims. We are in control of our situation, but we must act on it with a great sense of urgency. So that's why we're here today. That's why we're doing this. I want to thank the panel. I want to thank everyone here for your time and attention, and I certainly want to thank the panel, Dale, Rob, and of course the smiling one, Rachel. Thank you very much, and give them a hand, please.